Good evening, everyone. Welcome to Vayomanasa Sanjeevani Monday webinar series. Today's topic of the day is low level of sodium in elderly, a panel discussion. To talk about this, we have two panelists, Dr. Kalpana Chandra and Dr. Arathi JS. I welcome Dr. Kalpana Chandra and Dr. Arathi JS to the session.
Thank you very much.
And today's moderator for the session is Mr. Jambunathan K. I welcome Mr. Jambunathan sir to the session. Welcome, sir. And I also welcome all the Zoom and YouTube participants to the session. On to you, Jambunathan sir.
Thank you, ma'am. Thank you, Lima. Good evening. Good evening to Dr. Kalpana Chandra,
Good evening, sir.
Dr. Arathi JS.
Yeah.
Those personally, Dr. Arathi, can you just, can you be on your video, ma'am?
Yes, sir. My video is switched on already.
Switched on already. Okay, ma'am. Thank you.
Oh,
Thank you. So, welcome to the resource persons of this evening. Coordinator of this program, Mrs. Lima. Students, staff, and volunteers in NIMHANS, the viewers and participants for this webinar from across the country and world. I have great pleasure in welcoming you to yet another edition of this fortnightly seminar being organized by Vayomanasa Sanjeevani, an outreach arm of Geriatric Department of NIMHANS, Bangalore. I am happy to introduce the resource persons of this evening, Dr. Kalpana Chandra, who is working as the Senior Chief Medical Officer in charge, Delhi Jail Board, Delhi, and Dr. Arathi JS, a final year DM student from NIMHANS, Bangalore. I shall first introduce Dr. Kalpana Chandra from Delhi. She is highly educated and is having specialization in a number of medical fields. After obtaining her MBBS qualification from Mahatma Gandhi Institute of Medical Sciences, Sevagram, Vadra, Maharashtra, she has done her higher education in the following institutions: MD in Internal Medicine in Nagpur University, from Mahatma Gandhi Institute of Medical Science, Sevagram, same university, and the discussion topic in MD was comprehensive evaluation of the elderly, a topic which is very, very relevant to us for the day. I think we are happy to have such a resourceful person with us today. She has also done her PhD in pulmonary medicines, and the thesis topic was occupational lung disease in sewage workers. Again, she has WHO fellowship in antimicrobial resistance and Institute of Stockholm in Sweden. She has got postgraduate diploma in geriatric medicine from Indira Gandhi National Open University, IGNOU, and a postgraduate certification course in hospital administration from National Institute of Health and Family Welfare, New Delhi. So we are really fortunate to have such a resourceful person to talk to us about our sodium level. See, coming back to Dr. JS Arathi, she had her basic MBBS education from Calicut Medical College, Trivandrum, and she had her MD from MD in geriatrics, geriatric psychiatry, isn't it? Geriatric psychiatry from Calicut, and now she is pursuing her DM course in the final year as a final year student. Besides being working as an internal, as a doctor in NIMHANS, Bangalore. Gentlemen, as far as we are concerned, I tell you, let me be very honest. We are a set of seniors from across the country, and we are very passionate to know about our health. The only thing that is uniting us today is uniting all of us today is our passion to know about health, and especially this sodium level is something that we often hear. That is, somebody is saying that his sodium level was low, therefore he has fallen, or he has fallen down, or his sodium level has suddenly increased. So this sodium level is a topic that we often hear, but we really do not know what it is. And we are also not aware as to how to maintain our sodium level. What are all the tests that are available? So we are taking lots of medicines, certain medicines prescribed by the doctors, certain medicines of our own accord obtained from a friendly pharmacist. So how it is wrong, we are aware. We are not supposed to get medicine from any other person other than a doctor. But as a practice, I mean, what has happened is, as a matter of this thing, I mean, convenience, we always go to a pharmacist easily and get some medicines. See, this certain medicines either increase the sodium level or decrease the sodium level, and we get into the problem. So we would like to hear from you, the experts, on this sodium doctor. We are extremely thankful to you for coming here and giving us a lecture on that. As a protocol, what we do is normally the presentation is being done by the panelists. Then after the presentation is over, I think we kindly permit us to raise certain doubts and in the form of questions. Kindly answer that. Now it is that forum is open to you, doctors. Please go ahead. First Dr. Chandra will make the presentation. Then Arathi, Dr. Arathi will make her next presentation. Then we will come. Thank you. Thank you.
Thank you, sir.
The floor is open to you, doctors.
Thank you, sir. Sir, I have logged in through my sister's ID, Dr. Meena Chandra. How is the weather in Bangalore? Today it has rained in Delhi and we are having connectivity issues. So, how is the weather in Bangalore?
Weather in Bangalore is quite nice, ma. In fact, we don't have rain. We did not have rains. In fact, it is now raining in Chennai.
Okay.
Therefore, because of the raining in Chennai, rains in Chennai, when Chennai rains, Bangalore also sneezes. Therefore, there is sneezing here. That's all.
Okay, sir. Sir, at the beginning, at the outset, I would first like to thank Vayomanasa Sanjeevani for giving me this opportunity to be with you. And I would like to start my presentation now. We are having a bit of connectivity issue. So I would shut off my video, but I think I'll be audible and
Doctor, you are audible.
Yeah.
You are audible.
Okay.
No problem.
Can you see my slides?
Yeah, your slides are there. Your slides are there.
Okay. Oh, yeah.
Now you can. It's a fine one. Everything is.
Okay. Yeah. So topic for today's discussion is hyponatremia. Hyponatremia is the clinical term, and in general, we say when the sodium levels, salt levels are low in the body. Now, what is the normal sodium level? That is about 135 milliequivalents per liter. And hyponatremia is one of the most common electrolyte imbalance that we encounter in clinical practice. Just wait.
You can go to the next.
I shall be covering my talk under the following headings. One is the just give me one. Yeah. So, as I said, hyponatremia is a clinical condition characterized by low sodium in the body. That is, the normal value is about 135 milliequivalents. And when it is less than 135 milliequivalents per liter, we call it hyponatremia. Now, hyponatremia can be divided into 3 groups depending upon the severity. So when the levels of sodium are between 130 to 135 milliequivalents, we call it mild hyponatremia. When the levels are between 125 to 130, we call it moderate hyponatremia. And when the levels are less than 125, we call it severe hyponatremia. Just give me 1 minute. There is some problem which is occurring with the slides.
This is fine, doctor.
Yeah, just. Now, hyponatremia can also be classified as depending upon the serum osmolality. Now, serum osmolality is a clinical term that we use, and we measure serum sodium levels, we measure the glucose levels, and we measure the blood urea nitrogen levels, and we decide the osmolality of the plasma. Now, hyponatremia can occur when the serum osmolality is normal. The normal osmolality of plasma is between 285 to 295 milliosmoles per liter. It can also occur in the setting where there is low serum osmolality, that is, the levels are less than 280 milliosmoles per liter. And this can also occur where the serum hypoosmolality is very high, that is more than 295 milliosmoles per liter. Now, coming to the causes of hyponatremia, the hyponatremia which occurs when the serum osmolality is normal is usually due to hypertriglyceridemia, hypercholesterolemia, and hyperparaproteinemias. Usually, this does not require much of treatment. Then, when the serum osmolality is high, hyponatremia can occur, and this is usually due to hyperglycemia. This is use of mannitol to lower down brain pressure. Then it can also be because of radio contrast usage. Now, the most common thing that we encounter is when the
Recording in progress.
Can you sync the slides now?
No, nothing. Yeah, I'm seeing the slides now. Now it's fine.
Oh, now it's fine. Okay. So, like I told, that hyponatremia is graded according to the severity as mild, moderate, severe. Mild is when the levels are between 130 to 134 milliequivalents per liter. Moderate hyponatremia is when the levels are between 125 to 129 milliequivalents per liter. And severe hyponatremia is when the levels are less than 125 milliequivalents per liter. Now, as I told you that it is one of the most common electrolyte disorder that we encounter in clinical practice. The incidence is around 1% and the prevalence is around 2.5%. This disorder is usually found in the elderly, in females, and in hospitalized individuals. Though it occurs in around 20% of the hospitalized patients, only 3 to 5% of the hospitalized patients have moderate to severe hyponatremia, with the sodium levels being less than 130 millimoles per liter. In ICU patients, around 30% of them may have hyponatremia. And when hyponatremia is present in hospitalized patients, it is associated with an increased risk of death. Now, coming to the causes of hyponatremia, as I was telling you that we measure the osmolality of the plasma, and according to the measurements, we can classify hyponatremia as ones which are where there is normal osmolality, and the second when the osmolality is low, and third where the osmolality is high. So in the conditions where osmolality is low, common causes are excessive vomiting, the use of diuretics, drinking too much of water, there is excessive diarrhea. Then patients having heart, kidney, and liver problems, they are susceptible to hyponatremia. Then dehydration, and there is inadequate salt intake. Then when there is, in a hospitalized patient, there is fluid shift from the intracellular compartment to the extracellular compartment. So these are the most common causes of hyponatremia that we see in clinical practice. Now, like I was telling you, we have high volume hyponatremia, we have normal volume hyponatremia, we have low volume hyponatremia. The high volume hyponatremia occurs when both the sodium and water content of the body are increased. And the most common causes are liver cirrhosis, congestive heart failure, nephrotic syndrome, and excessive drinking of fluids. Normal volume hyponatremia occurs. The most important cause is syndrome of inappropriate secretion of ADH. Then hypothyroidism. There is a condition called as beer potomonia, where a person binges on beer. Then it is also seen in normal physiological change of pregnancy, which is not relevant here, but it is also a cause of normal volume hyponatremia. And it can occur in reset osmostat also. Hypovolemia, due to occurring in the setting of low volume, is seen in severe diarrhea, in vomiting, in prolonged exercise and sweating. Then there are conditions such as Addison's disease, pancreatitis, and diuretic use, which cause hyponatremia. The most common diuretic which cause hyponatremia are thiazide derivatives, and ACE inhibitors are also linked with hyponatremia, and usually for hypertension we use the combination of these two. So in the first week, especially in women, when ACE inhibitors and diuretics are started together, there is a chance of going into hyponatremia, and it needs to be monitored diligently. Now, coming to the signs and symptoms that we encounter when a person will have hyponatremia. When there is mild hyponatremia, that is, the levels are between 131 to 135 millimoles per liter. The symptoms are usually nausea, vomiting. Patient may have headache. They may be confused. They may feel lethargic, fatigue. There is loss of appetite. They may feel irritable. Muscle weakness can occur. Spasms and cramps can occur. Now, in severe hyponatremia, where the levels are usually less than 150 milliequivalents per liter, the symptoms are confusion, seizures, coma, and cerebral edema may occur. There is a condition called as hyponatremic encephalopathy. Brainstem herniation can occur. Brainstem compression can occur. Patient can land up in respiratory arrest. There can be accumulation of fluid in the lungs. And if untreated, death can ensue. Now, how do we go about diagnosing hyponatremia? Whenever a patient comes to us, we have to take a detailed history. We assess for risk factors. We look at the symptoms. Then we see the duration, the chronicity, whether the patient is having chronic hyponatremia or it is an acute emergency. We do a detailed neurological examination. We see the neurological symptoms, and we see for comorbidities like hypertension, uncontrolled diabetes, hypothyroidism. Then whether patient is on any drugs, we take a detailed history of the drugs that they are using. And we go about the physical examination by monitoring the vital signs. We assess for the level of dehydration, and we do a complete systemic examination. Now, the laboratory testing includes monitoring of serum electrolyte, urine electrolyte, that is urinary sodium. Then we calculate the osmolality, and any other investigation pertaining to the diagnosis of the patient that is done. Now, what is the treatment? Hyponatremia is an emergency, and one must consult your physician. If you are having symptoms of diarrhea, uncontrolled diarrhea, vomiting, your patient is having confusion, patient is having fall, patient is having out of proportional fatigue, one must rush this patient to the nearest hospital for complete assessment and management. Now, the treatment, as I told you, it depends upon the volume status, whether the patient is euvolemic or he is volume depleted. And also we see for the duration of hyponatremia, whether it is acute or it is chronic. And we see whether the patient is having symptoms or not. And then we go about treating the hyponatremia depending upon the cause of hyponatremia. So what we do is that we measure the osmolality and we go about slow sodium correction. Remember, sodium correction has to be very slow. Otherwise, there is a condition called as central pontine myelinosis, which may occur. Remyelination of brain may occur, and the nerves may occur if hypertonic saline is given too fast. And we have to limit the fluid intake. We have to give proper diet. We have to give proper salt intake, and we have to give supportive care. And whatever medicine, if needed, if it is indicated by the doctor, that has to be given. Now, acute or symptomatic hyponatremia, one should not correct changes rapidly. So what we do is that maximum rise that we plan is 1 millimole of sodium per hour is to be connected if the setting is acute hyponatremia, and 15 millimoles per liter per day if there is chronic hyponatremia. We use a loop diuretic like furosemide to avoid fluid over. And in India now, vasopressor antagonist such as Torat is available, which can be used to treat hyponatremia, and we treat the underlying cause. We replace the sodium and water at the same rate that they were lost. Okay. And if the patient is having asymptomatic chronic hyponatremia. Here we go about by restricting the fluid. We give ADH antagonist like I told you, and we treat the underlying cause. So in summary, hyponatremia is an electrolyte imbalance. It is caused by too little sodium in the body in proportion to water. Symptoms like nausea, vomiting, loss of appetite, headaches, weakness, fatigue, confusion characterize hyponatremia. In severe cases, complication can result in severe brain damage. For a general person, treatment includes drinking the right amount of water in proportion to how much sodium you are losing, managing the underlying conditions, and eating a balanced diet. Thank you. And if there are any questions, then I'll be happy to take them.
Before questions, Dr. Arathi, would you like to, would you like to ask anything? Would you like to contribute?
Yes, sir.
Yeah.
So, like, hyponatremia is not my area of expertise, but the role of a psychiatrist comes when in two situations. Like, we come across people with hyponatremia or low sodium levels in two situations. One is when people come to us, present to us with the manifestations of low sodium levels. There is a condition which is called delirium. For all practical purpose, in simple terms, I can tell that when sodium levels fall, it affects your brain, and sometimes you can present with some psychiatric symptoms and sometimes memory disturbances. You may see things which are not there. You may hear things which are not there. You may develop fear. Your mood fluctuate. You can have mood fluctuations. You can become drowsy, and you can get disoriented. So these are the situations in which the family brings the patient to us, telling that they are having some psychiatric issues. So that is the first situation. So in this, I would like all of you to take this take-home point that there is a possibility that when low sodium levels are there, you can develop such psychiatric or cognitive or memory-related manifestation. The second situation is when, as a result of our treatment, as a result of some of the drugs that we are prescribing, we find patients developing low sodium levels. So that is especially with the antidepressant medicines that we give, there are some people who tend to have low sodium levels. But that is all a situation of risk-benefit ratio, where we will try to switch on to less like better option of antidepressant, or we will try to manage with the available options. So these are the two situations. So, and when the low sodium levels are there, like we, of course, we liaison with physician and try to manage better so that the patient can benefit. So that is what I want to add on to it. I will also take questions.
So, Dr. C, before that, when do you consider a patient to be on, when do you say that a person needs to consult a doctor with regard to this sodium imbalance? And what are all the easy tests to find out that whether there could be a sodium imbalance as a layperson?
As a layperson.
Yes, doctor.
Yeah. See, as a layperson, if you are hypertensive, if you are on medications, like I told you, in women, if we give a combination, and that we use very often, we give ACE inhibitors and we give diuretic. And diuretic, if it is a thiazide diuretic, it has a great chance of causing hyponatremia. So once, if your physician, if an elderly is started on any antihypertensive drugs, especially ACE inhibitors, after first week, if you get symptoms of tiredness, weakness, fatigue, okay, headache, and confusion is occurring, you must tell your doctor and he will get your electrolytes monitored. Then there are patients, cardiac patients who are on Codron. Codron is a drug which is used to control heart rate. So if you are on these drugs, you must talk to your doctor if you are having any rhythm disturbance, if you're feeling uneasy, if you're feeling the quantity of urine is not okay, you are going into confusion, then you must consult your doctor. Then most common cause, in elderly is when they travel outside, they develop diarrhea, they develop vomiting, and if it is not treated in time, it can cause hyponatremia, and even unconsciousness may occur. Then there are certain conditions such as, people who go on binge beer drinking, like I was telling, beer potomania. Then patients who are having renal failure. If after dialysis also you are not, they do monitor electrolytes, but in between the session, if you feel drowsy, if you get headache, if you get out of proportion fatigue, you must immediately inform your doctor. Then patients with liver disease, they are also, because we are giving medications plus liver itself is disease, then also they are at a risk of developing hyponatremia. Now with the use of drugs, good drugs, hyponatremia due to congestive heart failure, the incidence has gone down because we have very good drugs which can monitor and do not cause hyponatremia on their own. So, and then, especially in hot weather, if there is dehydration because of any cause, sweating, you lose sodium, then vomiting, or if you develop diarrhea, you must always consult your physician. And another thing I would like to say is that, there is a recent trend that people are using low sodium salt. So what does low sodium salt have? It has, the sodium content is low, but the potassium chloride content is more. So these patients are the one who will go into hyperkalemia and they will have associated hyponatremia. So one has to be very vigilant. And patients who are of tuberculosis, elderly patients staying alone, developing tuberculosis, they are also at a risk of developing hyponatremia because of adrenal malfunction. And there is a condition called as syndrome of inappropriate secretion of ADH. ADH, antidiuretic hormone, is the one which is regulating our electrolytes in the body, especially the sodium level. So there also, then if your patient is having having a chronic kidney disease, nephrotic syndrome, so here your nephrologist also will keep a watch on your electrolytes. Okay. And if you have any other condition, like there is a case of head injury, if you have, there is too much of pain, post-operative patient also, when they are having increased pain, they are also susceptible to develop hyponatremia. However, it is once they are admitted, it is usually the responsibility of the treating physician who will monitor the electrolytes. But for common public, if there is hot weather, if you are having any comorbid conditions, if there is out of proportion fatigue, confusion, fall, you must consult your doctor promptly. Another most important cause of hyponatremia in elderly especially is the use of NSAIDs, the non-steroidal anti-inflammatory drugs. They are the ones, because almost everybody these days in the elderly is using one form of NSAID and all. So it is very important to get your electrolytes measured on a regular interval.
That's right, doctor. That is, most of us are undergoing this health checkup.
Yeah.
At the time of health checkup, what exactly is the test, that any special test for this? I mean, any, yeah, can you suggest anything like that?
Yeah. See, once we are doing, we calculate the osmolality, serum osmolality, and the serum osmolality is, it is calculated by, there is a formula, there is an equation that is 2 into, we measure the sodium level in milliequivalents per liter, we measure the glucose level, and we measure the blood urea nitrogen. And there is an equation, depending upon that, we find the osmolality of the serum. And we also measure the urinary sodium. Now, there are techniques which measure the urinary sodium and urine osmolality. So these tests are specific for hyponatremia. One is electrolyte per se, sodium, and nowadays direct measurement of sodium is present. So confounding factors such as hypertriglyceridemia or hyperglycemia, they don't interfere in between. So this is the specific test for.
So thank you, doctor. So in our usual health checkup, we need to introduce, we need to have this check also, isn't it? That is right. One thing. And
yeah, we need to have.
Yeah, you were talking about salt and low sodium salt.
Yeah.
So this is a daily occurrence. See, we use salt on a daily basis. Which salt do you suggest is the best one?
No, the thing that has come up, most of the time, because as physicians advise, decrease the consumption of salt, and the marketing companies have come out with number of preparations like Lona and all, and where they say that, you can have this in plenty, which is actually wrong, because the potassium chloride increases, and potassium, when hyperkalemia is there, you will have hyponatremia occurring along with this. The sodium content is as it is low. So eat normal salt. But if you are hypertensive, don't eat in excess. And then you have to have proportional water intake as well. You cannot have water intake which is more than what your kidneys are excreting out. So once we are evaluating the patients, we see their creatinine clearance and we see their sodium potassium levels. And then we advise as to how much fluid they should take and how much salt they should take.
Oh, yeah, thanks, Doctor. That is, because sodium, salt and the sugar, they appear to be the major culprits.
Yeah.
In everything, wherever you go, the doctor either advises take less of salt, take less of sugar. So, but again, the market is flooded with, as you rightly pointed out, Doctor, market is flooded with so many types of salts. We are, actually, we are actually confused about that. See, somebody says the Himalayan salt is the best one. Somebody says, no, rock salt is the best one. Somebody says sea salt is the best one. So we do not know. That is why, I thought whether you can just give any specific advice on that.
See, Himalayan salts and the sea salts, if the source is natural, they are still all right. But the commercially made salts, where they specify that it has low sodium content in it, they are industrially made. So I feel that they should not be used. But yes, Himalayan rock salt and all, they are good enough. Though we advise our hypertensive patients to limit the intake of salt, we don't advise them to stop salt altogether because that will also cause problems.
Yes, Doctor. Yes. That's the real problem. Either too much or too little.
Yeah.
Both are the problem.
You have to find a balance,
Balance between that. So thank you, Doctor. Thanks for the excellent inputs. So now I will call people who have raised their hands. Mr. Ramnath has raised the hand first. So I will ask him to unmute and talk. Ramnath, you can talk.
I'm not from Chennai. Are you audible, madam? Okay.
Yes, you are.
So generally, the problem comes only for heart patients who is having a surgery, either open heart surgery or any other surgery, and also the brain patients, and also the lungs affected patients. One of my friends already operated upon 10 years back with that open heart surgery, and the doctor has advised strictly not to use salt at all. He is taking without salt food, and sugar, less content of sugar of coffee or tea like that. So how long it can be like that? He is fed up like anything. What to do, madam? Thank you.
He should take salt and he should go in for monitoring of his electrolytes on a regular.
Doctor advised not to take salt at all. Then.
No, I don't think so. Any physician can advise that don't take salt at all.
Going to Apollo Hospital for checkup every 3 months.
And like I was telling you, for heart failure, we have now got very good drugs which take care of heart failure, and they will also not cause.
What are drug, madam? What is the name of drug?
We have got.
What is the name
That
of
depends
drug?
upon the patient, patient profile, what is having for heart failure. Now we have valsartan, combination valsartan with sacubitril.
68 years old. 68 years old.
Yeah.
Got operated upon. Any medicine reliable?
You have to show clinically. See, a clinical assessment has to be done.
Okay.
What is like I was telling you, we have to ascertain your whether you are dehydrated, whether you are euhydrated, what is your cardiac function. Okay, like when the cardiac function is low, ejection fraction is less than 45%. Patients will, though we will advise sodium restriction, but we'll never tell the patient not to have salt at all.
Okay.
And we have to treat the heart failure aggressively. And once we treat it aggressively, even hyponatremia will not be a problem.
Okay. Thank you, madam.
Okay.
Now the next one is Sheila. Hello.
Namaste, madam. I'm
Namaste.
Sheila Kadur.
Sheila
So,
Kapoor.
is it any directly relation to the BP to lower BP to hypernatremia? Any difference between low BP or hypernatremia? I'm taking very low doses for BP tablet. I'm taking low doses. The lows are 2.5 mg like that.
See,
So,
yeah.
If along with taking the tablet, I'm use normal salt in my diet. I use the salt normally, not too much or too less. Is it okay? Some people tell you are taking tablet, along with that you're taking salt. It's not okay like that.
Okay.
Shall I
It's
take
okay.
normal diet? Shall I take salt in normal diet along with the tablet? Is it okay?
Yeah, you can.
And if sometime if I forget to take tablet, is it manages? No.
I couldn't get your question.
No,
Either-
what she said,
What,
doctor,
if you forget to take your antihypertensive medication?
Medication once in a while, if I forget I took it or not, like the doubt in a doubt, if I don't take,
Yeah.
it manages no. The intake of salt in daily diet, it manages no.
It's okay.
It's okay. Once in a blue moon, if you miss, that doesn't make much of a difference. Because our body, we have this antidiuretic hormone that comes into play and takes care of regulating the sodium levels in the body.
Okay, that doubt is cleared, madam. Everybody takes, you take tablet, or along with that you eat salt in your diet.
No, we never said, we never stop salt. Okay. So you take the medicine, but salt also has to be there. It should not be in excess. Yeah, but it is not that you stop salt altogether. No.
Oh, it's not
Yeah.
advisable. Yeah. Some people saying that you eat pickle. If some people have low BP, they can eat pickle like that. Is it right? What what I have thought.
See, what is the cause? First of all, you have to ascertain what is the cause of low BP. If your heart is not functioning properly, if your cardiac output is on the lower side, if you are having any, there are conditions such as autoimmune disorders, systemic sclerosis, where your BP may actually fall down. Okay, so it depends upon the condition. It doesn't mean that if you are having low BP, you start binging on salt. That is also not advisable. Okay. You can't binge on salt, and you can't say, because in pickles you have extra salt because it acts as a preservative. So the content of sodium in pickles is much more than what we normally consume in our dal sabji. Okay, so it is not that you go on a binge also if you are having low BP, and low BP needs to be seen in the context of the illness. Okay.
Once I was hospitalized, I got symptom in that measurement, the BP checking. No, it was showing little high BP levels. Since now I have not got any problems of BP problems like that. But still I take 0.5. This one Losar tablet, 2.5 mg.
You can continue to take.
I can continue.
Yeah.
Okay, madam. Thank you so much. Thank you.
Madam, only one question is that, are you taking the tablet in consultation with your doctor?
Yeah. They have told to continue, but
So that's the
they
best
have
thing.
given 50 mg. Now they reduced to 2.5 because I don't have any symptoms, but I don't want to stop. The doctors don't want to stop that BP tablets. So they have reduced the volume. It is 2.5 mg, 25 mg like that, 50 to 25 mg. So I can't stop. No, just I can take the tablets regularly.
Thanks, ma. Now, shall I move to next person, KGR Trust? Sir, please unmute yourself and talk, sir. KGR Trust.
Okay. Good evening to everybody. Madam, this is regarding the diagnosis. There is you suggest that the serum electrolyte and urine electrolyte and urine osmolality, etc. Whether these laboratory testings are available only in cities or in ordinary towns where plenty of this blood testing centers are available. Whether this
actually the routine testing, that is measurement of sodium, measurement of glucose, blood urea, nitrogen, all labs are. Then there is an equation that we use to calculate the serum osmolality. So that is done by a doctor. That is not done by the lab per se. Okay. And the amount of hypertonic saline that has to be infused or any medication, that decision is taken by the treating doctor, depending upon the condition.
Okay. Basically, if I understand correctly, this is available. I mean,
Yeah.
any blood testing will be able to detect this hyponatremia.
Oh, yeah. So sodium level, that's what I was telling you, that sodium level, now the techniques are such that we directly measure sodium. Okay, so there are no confounding factors, and most of the labs are doing. So if your level is less than 135 milliequivalents per liter, that means you are going into hyponatremia.
Okay. Thank you, madam.
Yeah.
So, doctor, there is a question in chat box. The question says, Mr. Narasimhan has asked, will sodium bicarbonate tablets help correction of hyponatremia in the short run? Will sodium bicarbonate tablets help correction of hyponatremia in the short run?
No, because you have to see volume, and uncontrolled this one will cause a problem. We don't advise sodium bicarbonate for correction of this one. We do advise vasopressin antagonist. Like I was telling, that Tolvat is available in India, and if it is an emergency, we infuse hypertonic saline, and that also has to be done very gradually, because there is a condition called as central pontine melanosis, which can occur if this is transfused too fast.
Well, I think best thing is to go to the consulting doctor and
Yes.
follow his advice,
Yes.
rather than treating ourselves with our own medicines, etc., etc. I think especially in these conditions. In fact, as you have rightly pointed out, doctor, from the synapses, if I can sum up this thing, the sodium is a very, very important part of our body.
Yes.
Then it decides the birth. I mean, it decides the life and death.
Yes.
That kind of importance it has got, and it has got a low level in most of the chronic conditions. Like, I mean, where there is a problem with the heart, where there is a problem with the kidney, where there is a problem with any other vital organ of the body, which has got a bearing on the life.
Yeah.
Therefore, I think this sodium level needs to be understood, treated, and correctly. I mean, sodium level needs to be evaluated only by a doctor.
Yeah.
Yes, we can go to a diagnostic center and have our blood tested, have our urine tested, etc., etc. But the test result have to be interpreted only by a doctor,
Yeah.
not by us.
Yeah. And sodium bicarbonate, it is used by nephrologists. They also use in advanced renal failure, where they find acidosis is there despite this one, and sodium losses and hyponatremia is occurring. Okay, but that also has to be under supervision. You just can't for any, I mean, if hyponatremia is there without any acid-based disorder, this should not be used. Sodium bicarbonate should not be used. In setting of acidosis, in setting of renal failure, patient on hemodialysis, yes, we do give, but not, and that too under supervision. We don't routinely prescribe that, okay, you are having sodium of less than 130, you take short-term. No.
So, Pagaraj sir, you have asked this question, how to get tested by laboratory. Have you got the answer, sir? Tangaraj sir? Tangaraj sir? Yeah. Please come, sir. Please.
My question is, mostly seniors are testing sugar only, but not salt and other sodium. Some lot of tests are available with blood or urine. Whether this sodium deficiency or excess can be ascertained blood test or urinal test. That is the.
Yeah, it is ascertained by the blood test, where we directly measure sodium levels, and in the urine also we can measure sodium. And like I was telling you, for calculating the osmolality, we have equations. So we measure sodium, there we measure blood urea nitrogen, and we measure the glucose level. And then
my question is whether we have to get tested from the laboratory and shown to doctor.
Yeah, this will be done in the lab.
Yes, that is
It
it.
will be done in the lab.
On prescription from the doctor, they will get samples and
Yeah.
give result.
Yes.
How to get I am affected by the sodium deficiency or excess? That is generally seniors are not asking a lot of tests. There are so many tests like that.
See, for specifically for hyponatremia, if you are on antihypertensive medication, like I was telling you, ACE inhibitors, or if you're on diuretics, or if you're on anti-arrhythmic preparations such as Cordaron, and if you're on any antipsychotic medications like SSRIs or MAO inhibitors and all, your doctor will get them monitored serially, so that you don't develop any side effect because of sodium loss. But if you get diarrhea, if you get unexpected fatigue, if you are getting lots of muscle cramp, if you have been in hot weather, if you are binge drinking beer, if you are on NSAIDs and you feel fatigue and decreased urine output, if you are undergoing a surgical procedure such as colonoscopy, yes, there is a risk of hyponatremia in all these conditions. And if you will go to your doctor, he will decide and order these tests for you.
Very long time we are reducing salt and oil as advised by the doctors.
Yeah.
We are not little sodium, the salt and a little oil like that.
Yeah, that's what I was telling, that it has to be in proportion how much salt you are taking. It cannot be excess in excess, or it cannot be very low.
Yes.
But in conditions like if you are maintaining, if you are normal, but if you develop diarrhea, if you have been in hot weather, okay, if you are having recurrent vomitings, if you are undergoing surgery, if there is a stroke, if there is a stroke, then obviously these are conditions where you will have, you can have hyponatremia, and your physician will monitor. I mean, most of us will monitor these.
Thank you, doctor. Thank you.
Yeah. Is it necessary to, next question is that, is it necessary to go to any specified specialist for this, for determining the sodium, for taking treatment about sodium levels, etc.?
See, for sodium level correction, okay, it is usually not done on an OPD basis. We admit the patient, okay, and we correct sodium once depending upon the level. So there is an equation, we calculate the total body water, then the level of sodium is monitored, and we correct till 135 milliequivalents per hour, and we give hypertonic saline. In patients who are having chronic hyponatremia, this is usually seen post-stroke. In cases of head injuries, this drug has come up, like I was telling you, Tolvat, and we titrate the dose. We start from 15 milligram per day, we go to 30 milligram, and we go up to 60 milligram. However, it cannot be used for a very long time because it is toxic to the liver. And if your patient is having cirrhosis along with the hyponatremia, this drug cannot be used. So management of hyponatremia is usually done in hospital setting.
In hospital settings only. It is not outpatient treatment as such.
No. Once we stabilize the dose of Tolvat, I mean ADH antagonist, that can be done on this one basis. But for initial this one must be admitted, because you have to monitor sodium levels frequently.
Oh, that's right. Therefore, it calls for admission in the hospital.
Yes, yeah, it does.
One more. Mr. Ganesh has asked one more question. Is low sodium level associated with common diseases like cold, mild fever, etc.?
Cold, mild fever.
No. No. See, if you are having lung infections in the form of aspergillosis, you are having pneumonias, you are having bronchiectasis, you are having tuberculosis, then there is a condition called as syndrome of inappropriate secretion of ADH. Okay, so there you might have this one hyponatremia, but common cold, yes, a big pneumonia, lower pneumonia, yes, you can land up in this. Then if you are having lung malignancy, bronchogenic carcinoma, that is a risk factor. You are having adenocarcinoma of colon, hyponatremia can occur. There are lymphomas, leukemias, where there is inappropriate secretion of antidiuretic hormone. Okay, so there you might land up in hyponatremia.
Excuse me. Am I audible? Am I audible?
You are, sir. You are, sir. Please go ahead.
Just a small query.
Ah.
For super saving patients like me, is it okay to take electrol? Because I had some low sodium problems some time back. I used to get bouts of giddiness, and I used to take a lot of water in Chennai during the summer. Because of that, I was admitted in the Amach hospital. They could not diagnose. Then only at the last resort, they found out that I had low sodium problems. So they gave me some tablets. Is it okay to take electrol for super citizens like me?
See, electrol you take only for mild hyponatremia. But if you are having diabetes, you know, hyperglycemia itself may cause hyponatremia. So don't take it without supervision. Mild hyponatremia, okay, you were working in, you were in the hot weather, your blood sugar levels are well controlled, okay, less than 200 mg%, okay, you can take. But severe hyponatremia, no. You always take medical advice.
I see. It's not okay.
ORS is not a panacea for all this one, for hyponatremia.
I see.
ORS not a panacea, doctor, but at the same time, as a first level drug, first level treatment for a person who is having diarrhea, I think normally this ORS is taken. That's a preliminary one.
Yeah.
That's not wrong, isn't it?
See,
it needs to be, we need to, go to the doctor and continue, take his advice and take his or her advice and continue or stop it. But basically, I think the first level of treatment in diarrhea is this ORS.
Yeah, it is for young patients. We do advise ORS, you know, but in elderly, one has to see if they are diabetic if they are having comorbid conditions like diabetes, like they are on ACE inhibitors, like they are on NSAIDs. So, and ORS is not a panacea for this. That's what I was trying to say. Yes, it can be started, but then once you are continuing, you take a medical advice as well. And if you land up in severe hyponatremia, then ORS is not going to help you.
That is right, doctor.
That's what I was trying to say.
Thank you, doctor. Thank you.
Yeah.
Thank you. And Dr. Mahesh has raised one question. How do you treat cerebral salt wasting syndrome?
See, the etiology of this is not well known, and depending upon the level of the sodium, we correct using hypertonic saline, and we calculate the total body water, and we measure the sodium level. We correct till, like I told you, 135 milliequivalents per liter. For females, you know, we take 50% as value, and for males, 55%. So once we calculate the deficit, then we slowly infuse, because like I told you, if it is infused very fast, then it can cause a condition called as central pontine malinosis, where the full quadriparesis can occur, and at times it can be irreversible. And then while we are treating, we restrict the fluid intake, and we use loop diuretics such as furosemide, and we try to treat the underlying condition, because usually this syndrome is also associated with stroke, with the tubercular meningitis, with syndrome with the subarachnoid hemorrhage. So this is a medical emergency. This cannot be treated in an OPD at home. It has to be, and frequent electrolyte and even pH correction has to be done.
I think that explains, doctor's doubt. Doctor, one more question is whether hyperthermia is related to urinary problem. Is it related to any urinary problem or urinary conditions?
See, kidney failure, advanced renal disease, nephrotic syndrome. Okay, so where there is hypervolemia and the kidney's ability to handle this water is low, their hyponatremia can occur. Then in Addison's disease, in adrenal insufficiency, we will have hyponatremia. because aldosterone doesn't work and there is inappropriate secretion of ADH. So a patient can land up in hyponatremia. And in CRF, in renal failure, at times, if you are using during dialysis, your patient can go into hyponatremia. So one has to be very vigilant. Nephrotic syndrome and advanced chronic renal failure, they are associated with hyponatremia.
So Chandrasekhar sir, sir, you have raised a hand. Sir Chandrasekhar. Chandrasekhar sir, I think he has raised hands, but he is not able to respond. And he is not able to unmute himself also.
So what is the optimal level of sodium chloride one should take, doctor, for normal daily? Optimal level of sodium chloride.
See, it depends upon your creatinine clearance. Okay. And it depends upon your sodium. It depends upon your sodium and creatinine levels and the disease the concomitant disease that you're having. And how much of this one, we measure the urinary sodium levels. We see whether how much sodium you are excreting in the urine. And depending upon that, we plan a diet and give it to you.
Okay, doctor. Thank you. Okay.
So it depends on one's medical condition as well. So it cannot be straight away prescribed as such, isn't it?
If everything is normal, say, if everything is normal, then what is the measure?
The normal diet, what you consume, if you're not hypertensive, if you're not on diuretics, if you're not on any antipsychotic drugs, if everything is normal, you continue to take this one. And the most important thing is, once you are drinking water or this one, solute intake has to be there. Otherwise, if you keep on drinking plain water, like it happens in marathons and all when they are running. So if adequate amount of sodium is also not taken along with the water, then you might land up in hyponatremia. Then people who binge on beer, the solute load is less. So they also go on, they also develop hyponatremia. So it depends upon the clinical conditions. If everything is all right, you will not land up in hyponatremia if you're fine.
Is there any measure like 1000 milligram per day or something like that?
In elderly is customized.
It is customized in elderly, because most of our patients will be having, like I was telling you, they might be on NSAIDs, they might be having painkillers, they might be on heart medications such as Cordron and other drugs. They might be having drugs taken for depression and all. So it has to be customized. Then what is their renal status? What is their liver status? Okay, so then we decide. And if they're having other comorbid conditions, see liver disease, chronic liver disease, renal failure, so we customize accordingly. And how much is he taking in a day? What is his urinary output? What is the urinary sodium? What is the urinary osmolality? These things are taken into consideration before prescribing how much salt. And then we assess, we titrate that, okay, at this level, this patient will maintain normal sodium level. It is a customized thing. It is not a thing that you write an OPD prescription. Okay, you take this much of salt. No, it is not like that. And elderly are difficult to treat because they're having multiple comorbidities. So one has to be very wise. We cannot send a patient in hyponatremia also. Okay, so it is a fine balance, you can say. You have to tune it.
Is there any limit for that adult, perfect adult?
Normal diet. Take normal diet, what you take, and avoid exposure to extremes of weather, like going in very hot summer. And if you develop conditions as vomiting, diarrhea, treat it promptly so that once infection is treated promptly, you will not land up in hyponatremia. And any underlying condition, where there can be inappropriate secretion of ADH, like I was telling you, malignancies, infections, large pneumonias. These are usually taken care of. Once you will have symptoms of any baseline disease, your doctor will monitor and will tailor therapy according to that. There is not a blanket treatment. Okay, you take this much of salt and everything is fine. No, it depends upon the condition that you are having.
Okay, thank you, doctor.
So, doctor, one more thing is that often we are taking this coconut water. This coconut water intake, how much is either empty or means empty stomach or after food, any duration or anything? What is the efficacy of this coconut water?
See, coconut water has a lot of potassium in it.
Sorry.
And like I told you, if it is taken too rapidly and too much, you will develop hyperkalemia and then simultaneous hyponatremia. Your kidneys won't be able to handle this one. So one has to be very vigilant while taking. It is not something that okay, you'll drink 3-4 times a day. No, and not more than 1 or 2, and that too under medical supervision in elderly. Young person takes no problem. Okay, but for elderly, yes, one has to be very careful because potassium hyperkalemia itself is toxic to the heart, and hyponatremia will cause cerebral edema. You can go into shock. Okay, so one has to be very careful.
So that's therefore it is not a be all and end all for everyone.
Yes.
See, normally people think that I can take coconut water and
Yes.
this tender coconut water is be all and end all for everything. It's a pinnacle for everything. That kind of that kind of a feeling is there, doctor.
Yes, you are very right.
Yeah, it's good that you have clearly stated that that kind of a feeling is not so good in case of elders.
Yeah.
Okay, for youngsters it is okay.
And marketing also is such that they are bringing out a lot of artificial coconut water, cocoa gel and all, which may not have actual, and they may just be having only chemical in it. Natural water also, natural coconut water cannot be taken in excess. Like I said, excess of anything is bad. This is a common reason. So don't take anything in excess.
Yeah, including coconut water.
And coconut water in a elderly patient, especially if you don't monitor their potassium levels, it can directly damage them and hyponatremia. So it's not a.
Okay, Mr. Narendranath has raised a hand. Okay, can you just raise your question, sir, Narendranath?
See, I'm 70, so the sodium chloride test. The test should be done once a year or something to check whether it is low or so.
See, if you are having hypertension, if you are having cardiac failure, your doctor will regularly get your electrolytes measured. Okay, and the usual test that we do, like I was telling you, was that we do a kidney function test. We see for chloride, we see for sodium, we see for potassium. These are done routinely. Okay. And if you are, if you're not having any symptom, as it is, your kidney function should be, in an elderly person, should be checked every 6 months. But if you are on medications, such as diuretics, thiazide diuretics, if you're on ACE inhibitors, if you're on antiarrhythmic drugs, if you're on any antipsychotic drugs, it has to be measured in accordance to your physician's treatment.
Okay.
So, doctor, what we are the take-home lesson is that today we have learned some very new terms.
Mr. Ramanath is raising his hands. Ramanath,
he has already raised his answer and I answered him, sir. I think he has also raised the question about this coconut water. Ramanath, do you have any other question? No, sir. I think he has exhausted his question, sir. And we are also beyond our time, sir. See, we should not. We should not play. Doctors might be very busy. We cannot just take that time like this because we have said that is 5 o'clock. It's already 5:10. So thank you very much, doctors. See, we had an excellent session. We understood something. So many new proper terms we understood today. And what are all the? How important is for a person to monitor himself through a doctor? And there are certain conditions that that cannot be cured in a outpatient settings, and one has to think of getting admitted also. See, these are all some take-home lessons for us, and this sodium level can affect somebody's brain as well.
Yes.
Yes, that is a brain. See, it has got a tendency to affect the brain. It has got a tendency to affect the heart. It has got the tendency to affect the kidneys. That means all vital organs of the body can be impacted if there is a irregularity in sodium level in the body. That's a very important take-home lesson for us, Doctor. Thank you very much. Thanks for your patience, and you have very patiently replied to all the questions raised by us. So therefore, I'm extremely thankful to you for that. I'm also thankful to Vayomanasa Sanjeevani. I'm also thankful to Dr. Arathi JS. She has also shared with us some of the important points, like because she's more a psychiatrist and she's treating people in the NIMHANS. She has got, and I understand that in some of the medicines prescribed for this treatment also has got a tendency to reduce the sodium level in the patient. Therefore, they need to monitor that and accordingly give the drugs to the patients, doctor. So thank you very much. Thanks. As a senior citizens, only way in which we can express our thanks is to pray God on your behalf and shower on all of you all the best in life. That is the only thing that we can do in return, because these things we will never be able to get information about all these things in a normal clinical setup, because the doctor is busy, the patient is also busy, and the next patient is waiting to enter into the doctor's room. So in such a situation, we don't get an opportunity to learn or create an awareness about all these things, doctor. Thank you very much for this, doctor. So may God bless all of you.
Thank you so much, sir. Thank you for your kindness and for giving me this opportunity to interact with all of you. Thank you very much, sir.
Thank you so much, madam.
Thank you, everyone.
Thank you.
Yeah, yes, sir.
Yeah, you can.
Okay. Thank you, Jampunathan sir, for moderating the session. And we are very grateful to you for your service to VMS. Thank you, sir. And I would like to thank our panelist, Dr. Kalpana Chandra, for her time and effort for giving us such an informative session to us. Thank you, ma'am.
Thank you so much.
And I would like to thank Dr. Arathi for joining us with today and for her support to VMS. Thank you, Dr. Arathi.
Thank you. Thank you.
I would like to thank our Zoom and YouTube participants for supporting us. With that, I would like to thank our partners, Government of Karnataka, Indian Psychiatric Society Karnataka Chapter, Karnataka State Legal Service Authority, Nightingale Medical Trust, Bangalore Apartment Federation, Happy 60+, Samadhana Counseling Center, Icon Life Sciences, REC Foundation, and NSC Foundation. Once again, thank you all. Have a good evening.
Good evening. Good evening, ma'am. Thank you. Bye.
Thank you once again.
Thank you. Good evening.